Okay, good morning. It is February 9th, 2023. We have Dr. Shelby Hines, our anesthesia resident, talking today about reversal agents in the post anesthesia area. She brought some donuts. So thank you. We're excited to hear your topic today. Go ahead. If you want to wipe any of this stuff out of the way. Okay. Hide.
That's okay.
Hide floating.
Yeah,
controls. There you go.
Perfect. Perfect. Thank you.
You're welcome.
Morning, everyone. I'm Shelby. Nice to see you all. Thanks all for being here. And thanks for being such great hosts to me in PACU over the past couple of weeks. I've learned a lot about anesthesia and kind of this side of things. So I really appreciate learning from all of you guys, and I look forward to working with you in the next couple of years of my residency too. And today we're going to be talking about reversal agents in the peri-anesthesia period, which I think is a really cool topic. It's kind of like the antidote to the spell in a lot of different ways. Some medications do have awesome reversal agents, some don't. So we'll kind of a broad topic, but we'll kind of hopefully do a good overview of that today. So agenda, we'll be talking about the reversal of opioids, the reversal of benzos, the reversal of neuromuscular blockade, and then some special examples. Here I have a picture of me with my two whippets. This is Uli and this is Stella. My husband and I adopted Uli like maybe about 3 years ago. So he's about 5 and she is new. We got her at Christmas this year. So she's only 6 months old and she's pretty crazy. Sorry, I don't think that's me. Here is some pictures of me and my life. This is me and my husband, Eric. This is me with my sister, Sarah Anderson, who is an OMFS resident here over the past 6 years. So if I look kind of weirdly familiar, that might be why. This is a picture with me and my family. I'm from Miami, Florida. Originally, I grew up there. My parents are still down there. This is a picture with me and my dad when I taught him how to use an ambu bag and how to intubate during a SIM session. And then that's a picture of a cappuccino that my husband made at home. We're really into coffee. And that is a picture of me free diving, which is something I like to do with my free time. So we'll start off with our talk today with a case study. So a 54-year-old man with a past medical history of obesity, sleep apnea, and hypertension is transferred to the PACU after GA for knee arthroplasty. Relevant medications administered during his anesthetic include Midaz, rocuronium, fentanyl, and morphine. He was reversed with Sugammadex and extubated in the OR. In the PACU, he is noted to have a respiratory rate of 8 and an SpO2 of 88%. On exam, the patient is somnolent. Dun, dun, dun.
Do I watch it with Zoom? No, I don't know I do it at all.
And so what could be contributing here? So, there's some common causes that a lot of you guys have taught me about the past couple of weeks: airway obstruction due to poor pharyngeal tone, residual effects of the anesthetic gas. But, less commonly, but always really important to consider when you're seeing a patient like this are a couple things: opioid-related respiratory depression, and then the chance of if there's any residual neuromuscular blockade. Oh, and then I put a picture of a dog getting anesthesia here. If you guys ever want something fun to watch on YouTube, there's some really cool videos about veterinary anesthesia and like veterinary post-anesthesia care, which are really fun to watch. There's a lot of similarities and a lot of differences. So opioids, this could obviously be a whole lecture in and of itself, but we'll just kind of be briefly touching on kind of the uses and the mechanism of opioids so that we can talk about the reversal. So opioids, indispensable in the practice of anesthesia and management of pain in the PACU. Lots of different types of opioids that we use routinely. Each has kind of unique features and profiles. And again, this could be a whole talk in and of itself, but most commonly the opioids that we use here in PACU are morphine, fentanyl, hydromorphone. The diagnosis of opioid overdose is best diagnosed on respiratory rate. I can't use my mouse for some reason. Oh, there it is. Kind of beyond the scope of this talk, but my point is that depression of ventilation is the primary adverse effect associated with opioids. So for all their great effects, that's kind of the adverse effect that we're most worried about. You know, when we use them intraoperatively, the airway might be secured, we're controlling ventilation, and so depression of little consequence. But here in the PACU, that can lead to hypoxia, hypoventilation, and even at the far end of that spectrum, kind of hypoxia to the brain and death if severe respiratory depression is left untreated. So luckily, we have this great opioid reversal agent called naloxone, also known as Narcan. Very well-known reversal agent. It completely reverses the central and the nervous respiratory depression effects caused by opioids via competitive antagonism. A couple of important things to know for naloxone is that it has a short half-life, so anywhere between 30 and 90 minutes, meaning that you may need to redose naloxone if you give it to antagonize a medication that has a longer duration of action than the naloxone itself does. In terms of dispensing, here's a picture of a vial of naloxone. Typically, it's dispensed as a 0.4 milligram per 1 ml vial. A couple different options for administering it. So if in an emergent case, you can draw up that 1 ml and you can emergently give either half a ml, which is 0.2 milligrams, or the full 0.4 milligrams, which would have kind of rapid onset, complete reversal of the opioids. But you can also titrate it into the response. So you can draw up that 1 ml of naloxone and mix it with 9 mLs of normal saline, meaning that you have 0.04 milligrams per cc, and you can kind of give 1 cc at a time and titrate it to the response so that you're not completely reversing the opioids and you're kind of titrating to the effect of reducing the amount of respiratory depression that you have. Something to be aware of that we've talked about is that if you were to administer a full dose of naloxone, then that particularly someone that's in someone that's dependent on opioids, and some side effects of that would be nausea, vomiting, tachycardia, hypertension, and it can even provoke seizures. So that's the first opioid, or the first reversal agent that we'll be talking about today, naloxone. And then moving on to our next kind of agent, and then the next agent that we'll talk about that reverses it is benzodiazepines. So benzodiazepines, as we all know, have multiple uses in the peri-anesthesia period. It causes anxiolysis, it causes anterograde amnesia. So it can be used as a preoperative medication, it can be used in sedation, it can be used actually as an IV, as an inducing agent for anesthesia. And then it can be used for the suppression of seizure activity. So lots of uses there. The mechanism of action of benzodiazepines is principally GABAergic. So you have binding to the GABA receptors, and it kind of increases the ability of endogenous GABA to depolarize the cell and has kind of an inhibitory effect on the CNS. The nice thing about benzodiazepines is that those receptors that benzodiazepines work on are primarily in the CNS. So it has like fairly little toxicity outside of the CNS. But if you were to see a patient, for example, that was had iatrogenically been given too many diazepines, things that you might see are slurred speech, ataxia, and altered mentation. So less so respiratory and like cardiac effects, but more so CNS effects. So say you had a patient that you felt like had too many benzodiazepines, or say like it's a brief sedation and we wanted to reverse that benzodiazepine for even if it was an appropriate dose. Midazolam is pretty unique in that it has a action that is readily reversed by an agent called flumazenil. So flumazenil, I've actually never given this medication, but my sister, who I showed a picture of that is an oral surgeon. She often does her own sedations. And so she uses this like on a daily basis, but that's because she's doing sedations in an office. They don't have a PACU. She wants to make sure that those benzodiazepines have been completely reversed before she sends her patients home. But suffice to say that flumazenil acts as an antagonist to benzodiazepines. If you can imagine that benzodiazepines are used to treat seizures, then you can kind of think of flumazenil as an agent that can precipitate seizures if you immediately withdraw the patient from getting benzodiazepines. Similar to naloxone, I want you guys to remember that flumazenil has a short half-life relatively, so it can, different numbers in different places, but anywhere from 40 to 80 minutes, and sometimes it's even quoted as having a shorter half-life than that. And then for dosing it, it's dispensed usually. This picture is a 1 milligram in a 10 milliliter vial, but it's also found in like 0.5 milligrams per 5 ml vials. And the dosing is pretty specific on the circumstance. But what I read was that you can give 0.2 milligrams per minute as an IV push, kind of over 15 seconds. And then similar to naloxone, you can kind of titrate that to the situation. And you can repeat for a max of 1 milligram over 5 minutes or 3 milligrams over the course of an hour. And again, the dosing is kind of determined on your desired degree of antagonism. Kind of an interesting note, I thought, is that while flumazenil will kind of reverse the CNS effects of benzodiazepines, it won't reverse the amnestic effect. So the patient will still have amnesia of what occurred before the flumazenil is given. So it's just kind of an interesting insight into how our memories are made and how benzos affect those. Moving on, and again, this is like a whole topic in and of itself, but just moving on to the kind of brief, big picture use of neuromuscular blockade and how we can, a good understanding of that can kind of help us understand how we reverse neuromuscular blockade. So neuromuscular blockers are used in anesthesia for various different reasons. One is that it helps us to facilitate intubation. Another is that it can help with surgical exposure, particularly in places where there's a lot of muscular tension. And so it can help the surgeons to have muscular relaxation. And then we also use neuromuscular blockade in emergent situations, like an emergent intubation or in the case of laryngospasm. So very helpful drugs. But of course, as we know, they don't provide any analgesia or anesthetic effects. They just work to as paralytics. And so that means a couple of things, that the patient needs to be adequately anesthetized or have appropriate analgesia, and then you also have to support their airways. And then just a couple of key, these are kind of like, classic back to basic question, diagrams on how the neuromuscular junction works. And I don't want to get too in the weeds with this because I'll probably say things wrong, and which would again be a whole lecture in and of itself. But a couple of key points that I want you to us to look at is that there's acetylcholine, which is a neurotransmitter that's involved in the neurosynaptic junction. There's acetylcholinesterase, which works to break that down. And then there's acetylcholine receptors. So those are kind of the key parts of this diagram here, and those things lead to contraction of your muscle. And then I have a picture of Uli and Stella here. I thought this was like sort of related because Uli is like chomped down on a toy and Stella's not, and he looks kind of more activated than she does, and she's not activated. So that's kind of like the acetylcholine binding to a receptor and causing muscular contraction. So neuromuscular blockade, these are really helpful for us to reverse the action of neuromuscular blockade. Actually I should say not reverse. This is like blocking the neuromuscular transmission in the first place. So these are the agents that I was talking about that we use in the OR. There's two kind of main groups, the depolarizers and the non-depolarizers. And the main clinically useful depolarizing neuromuscular blockade is succinylcholine. And then the non-depolarizers that we use are kind of a broad array, but most commonly rocuronium, vecuronium, and cisatracurium. And basically the depolarizing muscular blockers, they fire, they cause that muscle to continuously fire, and you have muscle paralysis because you're just not able to re-depolarize, as compared to the non-depolarizers, which kind of antagonize at the receptor. So they have a little bit of a different mechanism of action, and that of course affects the way that we're able to reverse them. Importantly, for succinylcholine, it has a very rapid onset, and it's rapidly metabolized. So for the most part, you don't need any reversal agent if you're using succinylcholine, with the exception if you're giving like very large doses or if you're giving repeated dosing, which can cause succinylcholine to kind of act as if it was a non-depolarizing muscular blockade. But that's kind of the main kind of two groups of neuromuscular blockade agents. And then in terms of monitoring, so we, of course, are routinely monitoring in the OR the depth of the neuromuscular blockade. And the three main questions we want to ask ourselves is it adequate? Are they overly blockaded? And can the neuromuscular blockade be reversed or antagonized? And so we use train of 4 monitoring, and in the future, we'll probably more often than not be using this type of monitor, which is more quantitative in nature. So this one, we're kind of just qualitatively assessing the type of muscular contraction that we're feeling, but clinicians it's been shown that we're actually quite bad at assessing that, and it's quite difficult to actually assess the fade of the block. So over time, we'll probably be seeing these more and more, but it'll just be like a big transition in practice. So, and then the depth of the reversal is really important for us in determining the dosing. So I won't go too much into this, but the count of the train of 4 is helpful for us in determining the dosing of Sugamidex, and then it's also essential for the dosing of neostigmine. So clinical signs of recovery. Oh, and then I'm going to skip ahead a little bit actually, because there is some, I feel like this is really helpful to see. There's some new guidelines that just recently came out about practicing the routine use of neuromuscular blockade, and then also how we monitor for it. And so this will be kind of interesting to see how our practices change in the coming months with those new guidelines. So I just wanted to put that as a preview. But a couple of things to go over for the clinical signs of recovery. So residual paralysis is the most common neuromuscular complication in the PACU from neuromuscular blockade. And as we already kind of touched on, it can lead to upper airway obstruction and just overall increases the risk of pulmonary complications here in the PACU and can prolong a PACU stay. And so it's really important that we reliably are able to assess for the recovery. And so, like we talked about, the train of 4 is the best method, but you can also do a 5-second head lift. So if you're ever concerned about a patient here in the PACU and that they might have residual neuromuscular blockade, you can ask the patient to lift their head for 5 seconds to see how they can hold that head lift. And that's a pretty reliable sign of neuromuscular recovery, although more recent studies, including that slide that I advanced to, has shown that it's probably less sensitive than we previously thought. But unreliable signs of recovery are things like eye opening, taking a normal tidal volume, and normal vital capacities prior to extubation. So all of those can kind of erroneously lead us to think that this is, and they may not be. So options for neuromuscular blockade are a few. You can allow the agent to diffuse away. You can allow the agent to redistribute, to be metabolized and excreted, or you can kind of choose to actively antagonize it by giving another medication. And so I'll talk briefly about a couple different options for those. Kind of the more like old school method, I would say, as a new young trainee, is use of acetylcholinesterase inhibitors. I've actually never used these on a patient because so often now we just use rocuronium and we use Sugamidex. But a lot of my older co-residents and then also young attendings, this was the go-to method. So the way these act in short is that they, if you recall back to the slide where we were talking about the neuromuscular junction, these agents act at that junction and they prohibit the metabolism of acetylcholinesterase that's here in this plot. They just help everyone your back kind of restore the acetylcholine that's left, and therefore you can kind of regain that strength. The examples of acetylcholinesterase inhibitors are neostigmine, pyridostigmine, ergothonium, and physostigmine. The downside to using these drugs, as you guys know, is that they have the side effect of a parasympathetic surge. So things like bradycardia, bronchospasm, increased secretions. Those are all things that can happen with this medication. So we will in tandem give antimuscarinics at the same time. And so these antimuscarinics like glycopyrrolate and atropine, they don't reverse the neuromuscular blockade. They just act in tandem with these acetylcholinesterase inhibitors to kind of prevent the unwanted and kind of gnarly side effects that they can have. And then finally, I'll talk about Sugamidex, which is kind of everyone's favorite drug and has really improved outcomes for reducing neuromuscular blockade in the PACU and therefore reducing the risk of pulmonary complications. Oh, and I put this picture of Stella and Uli because I kind of thought Stella was encapsulating him and deactivating him via an aggressive hug. But basically, the way Sugamidex works is that it forms a kind of complex. So it's actually similar to the complex that's in Febreze, where it's a cyclodextran that, you know how in Febreze commercials, they'll be like, encapsulates and like eliminates odors. So in that same way, it actually forms this compound around the rocuronium molecule and eliminates it by kind of sequestering it in that compound. Some side effects, there's potential for bradycardia, there's potential for allergic reactions, but for the most part, the side effect profile is so much superior to the acetylcholinesterase inhibitors that it's still, you know, shown to reduce adverse outcomes. And then something that is important to note too is that because it acts in that way where it can sequester molecules, it can also affect other medications, most pertinently here in the PACU for young women that are of conception age, is that the hormonal contraception can be affected for up to a week after administration. So it's really important to kind of counsel our patients to use an alternative method of birth control in that time period if they've received Sugamidex. And then here's just a slide about those new practice guidelines that are coming out, which in short kind of emphasize the importance of quantitative measuring for neuromuscular blockade and re-emphasize that Sugamidex is safe to use in most situations. And something that is coming in the future is that often, and I didn't talk about this, but oftentimes cis-atracurium is used as a neuromuscular blockade for the specific patient population of patients with ESRD or getting kidney transplants. And there's some new data and new guidelines that are coming out that shows that rocuronium and Sugamidex is actually a safe alternative to that. So that's something to keep in mind for the future. So we talked about naloxone opioid reversal. We talked about flumazenil, benzodiazepine reversal, and we touched kind of on the big broad topic of reversal of neuromuscular blockade. A couple of other like out of the scope of this talk, but reversal agents / antidotes that are kind of used in our shared space are the use of glucagon for beta blocker reversal, the use of protamine for heparin reversal, the use of intralipid, which has a really cool mechanism of action for reversal of local anesthesia systemic toxicity, and then the use of dantrolene for the reversal of malignant hyperthermia. There's also, there are also alpha-2 antagonists that would reverse dexmedetomidine, but they're not really used in humans. They're used in veterinary medicine for some reason, but they're not really used here, so they're not approved for use. I think they're used in Europe, but. Thank you. And then this is a picture of that I wanted to share of Uli and Stella. on the night that they figured out how to knock over our Furbo, which is like a little camera that has treats inside of it. And so this is a night vision picture of them about to knock over the treat dispensing device. They did. The video is really funny. Does anyone have any questions? I know that's a lot of different topics covered. And I might not be able to answer them, but any questions that came up?
Anyone online have any questions?
No, I'm good. Thank you.
Assuming would be used for if you're like what clinical situation you would use. So cause of the, like say you had a patient that had respiratory depression, signs of opioid overdose would be like pinpoint pupils, decreased respiratory rate, apnea, as compared to like incomplete neostigmine reversal. First of all, you wouldn't use that. You would only use neostigmine if they had been like incompletely reversed with neostigmine. So it wouldn't be appropriate to give if they had gotten Sugamidex, for example. But if they like didn't have a sustained head lift, if they, had decreased muscular tone, that would be a situation in which like you'd be more on alert for incomplete reversal versus opioid intoxication. But I think it can be really hard to tell, like if I've noticed that and I try to kind of include that in my example, like if a patient comes, it's hard to kind of discriminate right off the bat why they're hypoventilating. Could it be sleep apnea? Could it be opioid? And all these things can also have synergistic effects too. But it kind of depends on the clinical suspicion, depends on what medications they got in the case and the dosing of those medications.
Thank you. I think we're good. Thank you. That was great. Yeah. Thank you. And thank you for the donut.
Oh yeah, please have some.
I just want to make sure I got everybody, which I think I did. Kathy.
I should have done that before.